Hello, learners. Welcome to Lecture 21 of this module on Public Health Policies and Programs of RCH. In the previous lecture, we examined monitoring and evaluation systems and saw how they help track progress and guide improvement. Today, we shift our focus to the barriers that continue to hinder service delivery in RCH. Despite significant investments and progress, many challenges persist, ranging from resource constraints and systemic inefficiencies to cultural barriers and inequities. Understanding these challenges is crucial because they form the context within which policies must operate. By the end of this session, you should be able to identify the major gaps in RCH services, analyze their causes, and think about strategies for addressing them. The introduction to challenges in RCH service delivery begins with acknowledging that while India and many countries have made progress in maternal and child health, large gaps remain. The challenges appear at multiple levels of health system. At the systemic levels, issues like weak infrastructure and poor financing dominate. At the provider level, shortages of trained staff and lack of motivation creates barriers. At the community level, cultural beliefs, gender dynamics, and awareness gaps hinder utilization. Together, these factors produce an uneven landscape whether some populations access comprehensive services while others remain deficient and deprived. Recognizing this multi-level nature is the key to framing solutions. Systemic challenges create the foundation on which service delivery struggles. Many facilities they lack the basic infrastructure such as electricity, clean water, and functional labor rooms. Supply chains for essential drugs and contraceptives are often unreliable, leading to frequent stockouts. Financing for reproductive child health through improved under schemes like the National Rural Health Mission is still inadequate and sometimes poorly utilized. Governance issues such as delays in fund disbursement and lack of accountability further weaken system performance. Without addressing these systemic weaknesses, frontline services cannot be expected to function optimally no matter how well intentioned the policies may be. Additionally, persistent human resource gaps, vacant specialist posts at community health centers, undercut quality and continuity of primary health centers care, weak logistics management information system, and poor last mile transport compound stockouts, even when state warehouses are adequately supplied. Fragmented data systems limit timely feedback. Health management information system reports are often delayed, incomplete, or not used to course correction. Referral pathways remain fragile despite the Janani Shishu Suraksha Karikram and emergency ambulance services, leading to avoidable delays in obstetric and newborn emergencies. Maintenance budgets for water, sanitation, and biomedical equipment are insufficient, so small breakdowns cripple whole facilities for weeks. Social accountability platforms like Rogi Kalyan Samitis, village health, sanitation, and nutrition committees are under resourced and irregular, weakening community oversight. Convergence with integrated child development services and school health and wellness program is inconsistent, causing service duplication and missed opportunities. A systems strengthening approach under the National Health Mission must therefore prioritize reliable financing, transparent procurements, robust LMIS, sustained human resource planning, and real time data use, without which program guidelines will not translate into outcomes. Human resource shortages are perhaps the most persistent bottleneck of RCH. There are simply not enough doctors, nurses, and midwives to meet the population's needs. The problem is not only of numbers but also of distribution. Urban areas are relatively better served, while rural and remote regions face acute shortages. Absenteeism among health workers further reduces service availability. Even when staff are present, motivation is often low and opportunities for skill upgradation are limited. This leads to poor quality of care and undermines community trust. Strengthening human resources requires long term planning, incentives, and continuous training. Infrastructure challenges remain a serious obstacle to RCH service delivery. Many primary health centers function without sufficient space, equipment, or staff. Transport and referral systems are weak, making it difficult for women in emergencies to reach facilities in time. Even when facilities exist, they often lack basic amenities like clean toilets, clean drinking water, and electricity, which discourages women from seeking institutional deliveries. Emergency obstetric care centers, though critical, are limited to number and unevenly distributed. These deficiencies significantly compromise the effectiveness of maternal and child health interventions. Reliable supply chains are lifeline of any health program, yet in RCH they remain fragile. Stockouts of essential medicines, contraceptives and vaccines are frequent, particularly in rural facilities. Cold chain maintenance, vital for immunization, often suffers due to inadequate equipment or electricity shortages. Weak logistic management systems fail to anticipate needs and distribute supplies efficiently. These lapses create frustration among both providers and clients, leading to loss of confidence in public health systems. Strengthening logistics requires investment in infrastructure, technology, and human capacity for supply chain management. Financing remains a critical challenge in RCH service delivery. Budgets allocated to maternal and child health are often insufficient compared to magnitude of need. Even when funds are sanctioned, delays in release slow down implementation. As a result, families often end up bearing high out of pocket costs for deliveries, medicines, and diagnostics. Despite schemes intended to provide free care, weak financial management system also leads to underutilization of available resources. Addressing these financial gaps is essential for achieving equity and reducing the catastrophic out of pocket expenditure among the vulnerable families. Governance challenges are deeply intertwined with the service delivery gaps. Weak supervision means that facilities and workers often function without adequate oversight or performance review. Lack of transparency in procurement and utilization of funds reduces accountability. Political interference sometimes leads to misallocation of resources or prioritization of short term goals over long term sustainability. Community oversight mechanisms such as the village health sanitation and nutrition committees remain underutilized or poorly empowered. Without stronger governance and accountability, investments in reproductive and child health risk being diluted and trust in the system continues to erode. To strengthen governance, there should be establishment of clear standard operating procedures for supervision with quarterly joint reviews by district health societies under the National Health Mission. Mandate e-procurement through the government e-marketplace and public expenditure tracking to improve transparency from sanction to last mile spending. Institutionalize social accountability, regular Jansunvai, community scoreboard cards, and active Rogi Kalyan Samitis. Institutionalize social accountability, regular Jansunvai, community scoreboard cards, institutionalize social accountability, regular Jan Sunwai, community scorecards, and active Rogi Kalyan Samitis with follow through action reports. There should be creation of real time dashboards integrating HMIS and LMIS data with independent third party audits to deter data fabrication. There is also a need of protect program decisions from political capture by using need based, formula driven allocations and publicly posted criteria. Build governance capacity of block program managers and medical officers through training in public finance management, contract management, and ethics. Finally, Operationalization of grievance redressal committees and timelines with citizen charters at primary health centers and community health centers, linking leadership performance appraisals to compliance and outcomes. Service quality is an important as coverage, yet it remains a weak area in RCH delivery. Many facilities adhere to standard treatment protocols. Many facilities fail to adhere to standard treatment protocols, leading to inconsistent and sometimes unsafe care. Reports of disrespectful maternity care where women experience neglect, verbal abuse, or lack of privacy discourage utilization of institutional services. Follow up and continuity of care are often missing, with postmortem care neglected. Infection control practices are inadequate in many facilities, creating avoidable risks. Improving quality requires not only technical inputs but also attitudinal change and accountability mechanisms. Family planning services illustrate the interplay of systemic and social challenges. In many areas, the range of available contraceptive methods is limited, restricting choice for couples. Stockouts of contraceptives further disrupt continuity of use. Counseling is often inadequate, leaving clients poorly informed about side effects and proper usage. Cultural barriers, gender dynamics, and myths about contraceptives discourage uptake. These gaps not only undermine the right to informed choice but also limit the effectiveness of population stabilization strategies. Addressing them requires strengthening both supply and demand side interventions. Maternal health continues to suffer from gaps in both availability and quality of services. Emergency obstetric care, though emphasized in national programs, is still not universally available. Many districts lack fully functional facilities with cesarean section capability or blood transfusion services. Referral systems are often poorly organized, leading to the three delays: delay in recognizing complication, delay in reaching facilities, and delay in receiving care once there. Furthermore, maternal death reporting and audits are incomplete in many areas, reducing opportunities for learning and corrective action. These gaps directly contribute to preventive maternal mortality. These gaps directly contribute to preventable maternal mortality. Child health faces several persistent challenges. Immunization coverage has improved overall, but dropout rates between doses remain high, undermining protection. Nutritional deficiencies such as stunting, wasting, and anemia continue to affect large proportion of children despite supplementation schemes. Neonatal care, which requires specialized equipment and trained staff, is inadequate in many facilities, leading to preventable newborn deaths. Postnatal follow up is weak, and many infants slip through the cracks after discharge. Bridging these gaps requires not only technical resources but also strong outreach and follow up mechanisms. Adolescents are often neglected in RCH service delivery. Awareness of sexual and reproductive health is limited, with myths and misinformations prevailing. Services tailored to adolescents, such as counseling, contraception, and mental health support, are not widely available. And where they exist, they are often not adolescent friendly in approach. Social stigma around discussing reproductive health issues discourages adolescents from seeking care. Gender norms further constrain girls' autonomy to access services. These gaps leave adolescents vulnerable to early pregnancies, unsafe abortions, and sexually transmitted infections, which have long term consequences for their health and well being. Equity remains a major challenge in RCH service delivery. Rural populations often have a poor access to services compared to urban residents. Socioeconomic status also plays a defining role, whether families can access private care while poor households rely on under resourced public facilities. Marginalized groups such as scheduled caste, tribes, and minorities often face both systemic neglect and social discrimination in healthcare. These inequities undermine the principle of universal health coverage and contribute to persistent gaps in maternal and child health outcomes across the country. Addressing them requires targeted strategies and inclusive planning. Gender dynamics and cultural beliefs often act as invisible barriers in RCH. In many households, patriarchal norm means that women have a little say in their own health decision, including whether to seek antenatal care or use contraceptives. Male partners or in-laws often control such choices. Traditional beliefs sometimes encourage home deliveries even when facilities are available, increasing risks to mothers and newborns. Myths about family planning methods and mistrust of modern medicine further discourage uptake of services. These cultural and gender related barriers show that health interventions must be accompanied by social change efforts. Awareness and information gaps are significant obstacles in RCH programs. Many women and families are unaware of importance of antenatal care, institutional deliveries and child immunizations. Health literacy levels are low, particularly in rural areas and among the marginalized group of population. Outreach activities such as health education campaigns are not always consistent or effective. Myths and misconceptions, for example, that contraceptives cause infertility or colostrum is harmful, persist and discourage healthy practices. Bridging these gaps requires continuous community engagement and culturally sensitive health education. The private sector plays a large role in RCH service delivery, but it presents its own challenges. Quality of care is highly variable, with some facilities offering excellent services while others provide substandard or unsafe care. Costs are often very high, leading to significant out of pocket expenditure that pushes families into debts. Regulation of private providers remains weak, with limited enforcement of standards. Partnerships with the private sector, as we discussed in Lecture 19, can expand access, but without proper oversight, they can also exacerbate inequities. Strengthening regulation and integrating private providers into broader public health goals is essential. Referral systems are a critical link in RCH service delivery but remain weak in practice. Coordination between sub-centers, primary health centers, and higher level facilities is often poor, leading to delays in care. Transport is unreliable and communication between facilities is minimal, leaving patients stranded during emergencies. For maternal complications or neonatal emergencies, these delays can be fatal. Many referral systems function only on paper without operational support. Strengthening referral linkages with reliable transport, communication networks, and clear protocols is essential to ensure timely and effective care. Training and supervision of health workers are critical determinants of service quality. Many providers, particularly at lower levels, receive inadequate pre service training, leaving them poorly equipped to handle maternal and child health issues. Opportunities for in service training are limited, and when they do occur, they often focus on theory rather than practical skills. Supervision tends to be inspection oriented rather than supportive, which demotivates staff. Without proper mentoring and skill enhancement, frontline workers cannot provide the quality of care expected from them. Investing in ongoing training and supportive supervision is essential to bridge this gap. RCH service delivery often suffers from programmatic fragmentation. Multiple vertical programs such as maternal health, child health, family planning, and nutrition operate with separate budgets and reporting systems. Coordination across departments like health, women and child development, and education is often weak. This leads to duplication of efforts in some areas and neglect in others. Beneficiaries are left confused by overlapping schemes and inconsistent messages. A more integrated, convergent approach is needed to ensure that all aspects of reproductive and child health are addressed in coherent and efficient manner. Although we emphasized monitoring and evaluation in the previous lecture, it is important to recognize the gaps in monitoring and evaluation themselves. hinder RCH service delivery. Data quality is often poor, with underreporting, inconsistencies, and lack of completeness. Even when data are collected, they are not always analyzed or used efficiently for decision making. Feedback mechanisms are weak, so frontline workers rarely see how their data contribute to program improvement. As a result, monitoring and evaluation becomes a routine exercise rather than a tool for learning and action. Strengthening this link between information and practice is crucial. To close these gaps, establish clear SOPs for data validation and routine data quality assessments at facility, block, and district levels are necessary. Building of staff capacity in basic data literacy, like problem framing, indicator interpretation, and visualization, so ANMs, medical officers, and block program managers can translate the numbers into action. Configuration of health management information systems and DHIS with automated validation rules and completeness alerts, and triangulation with the LMIS and PFMS as necessary for coherence. Institutionalize monthly data to decision hurdles at primary health centers and CHCs where trends trigger specific corrective actions with owners and timelines. Use simple dashboards and scorecards at facility and community levels, including VHSNCs, to create transparent feedback loops and social accountability. Complete routine statistics with qualitative methods to explain the why behind the indicators. Incentivize timely, accurate reporting through recognition and supportive supervision rather than punitive audits. Finally, document learning in short after action notes so improvements are captured, shared across districts, and fed back into the RCH planning and budgeting cycles. Despite government schemes like JSY and JSSK, many families continue to incur high out of pocket expenditure for healthcare, medicines, deliveries, and diagnostic. Coverage of these schemes is uneven, and awareness among eligible families is limited. Some families face bureaucratic hurdles as accessing benefits. As a result, financial protection remains inadequate. Bridging this gap requires improve in reach and efficiency of financial protection schemes and ensuring that they reach to the beneficiaries at the most peripheral level. Community participation is recognized as essential for effective RCH, yet in practice it remains weak. Village health committees and other community platforms are often underutilized. Communities are rarely empowered to demand accountability from service providers. Grievance redressal mechanisms exist but are very weak in implementation. This lack of participation reduces trust in the health system and perpetuates service delivery gaps. While much attention is focused on rural health, urban health challenges are often underlooked. Rapid urbanization has led to large slum populations with poor living conditions and limited access to health services. Public facilities in cities are overcrowded and outreach services in slums are inadequate. These gaps in urban RCH delivery contribute to poor maternal and child health indicators in urban slums, which can sometimes be worse than rural averages. RCH is influenced not only by healthcare but also by education, nutrition, sanitation, and gender empowerment. Yet, coordination between these sectors is often weak. These missed opportunities reduce the effectiveness of RCH interventions. Strong intersectoral coordination is necessary to address the social determinants of health and achieve holistic improvement in outcomes. Technology offers great potential for strengthening RCH, but adoption remains limited. Digital health platforms, telemedicine, and mobile applications can expand access and improve monitoring. Yet, rural areas still suffer from poor internet connectivity and unreliable electricity. Health workers often lack on digital literacy to effectively use new tools. Bridging this gap requires investment in infrastructure training and supportive policies. India has strong policies and programs for RCH, but the challenges lie in implementation. The policy implementation gap means that ambitious goals often remain unachieved. Accountability for results is limited. This disconnect between the vision and reality undermines trust and slows progress. Beyond the traditional challenges, new and emerging issues are affecting RCH service delivery. The rising burden of non communicable diseases among women, such as hypertension and diabetes, complicates pregnancy and maternal care. Climate change is creating new risks. Migration and displacement, whether due to conflict or economic reasons, leave many women and children outside formal health systems. These emerging challenges demand adaptive strategies and expansion of RCH program to include broader health and environmental considerations. To summarize, RCH delivery faces challenges at every level of the system. Infrastructure weakness, human resource shortages, and financial constraints continue to undermine access. Cultural and gender barriers further restrict utilization. Quality of care remains inadequate and policy implementation gaps persist. Addressing these challenges requires a holistic approach. Only then can RCH services reach every mother, child, and family effectively. In conclusion, challenges and gaps in RCH service delivery are real, complex, and persistent, but they are not insurmountable. Recognizing these obstacles is the first step towards addressing them. Strengthening infrastructure, investing in human resources, ensuring financial protection, and embracing community participation are central to improvement. We must also look beyond healthcare to address social determinants and emerging threats. Ultimately, bridging these gaps is not just a technical exercise but a moral imperative. Every mother and child deserves access to safe, respectful, and effective care. By closing these gaps, we move closer to the vision of health for all. So, this is all for today's lecture. Thank you.